Oh, it's now live. Okay. Good afternoon. I'm hoping that everybody can hear me and can see me. My name is Robert Karanja. I'm the moderator for this amazing panel. And I would like to invite you to join us for a discussion on shaping Africa's healthcare landscape through inclusive innovation. And I have with me an amazing panel that you're going to be meeting just now in a few minutes as we, oh, there we go, thank you. That we'll be introducing just to be able to share with you about the work that they're doing and why inclusive innovation really, really matters. I'm also working with, co-moderating with my dear friend and brother, Bernard Shearer. So I'm going to invite him to quickly say hi and introduce himself and introduce the panelists as we get started. Bernard, over to you.
Fantastic, Robert. Thank you very much. Hello, everyone from wherever you're joining us across the world. Welcome to our panel session this afternoon in Nairobi, which is part of the Africa Healthcare International Conference hosted by AMREF. And today our panel really is about a very interesting topic on inclusive innovation in the healthcare sector. So I'm proud to introduce this very important topic, and we're going to look at what is it, who are the players, what are they doing, and what does it mean for universal healthcare in Africa. So allow me to introduce our panelists. I'm going to start with Diana Mukami. Diana is the Digital Learning Director and Head of Programs at AMREF Health Africa Institute of Capacity Development. She has experience in project planning, design, development, implementation, management, and evaluation. For more than a decade, Diana has been providing or has been involved in distance education in the public and private health sectors. These have included the implementation of in-service and pre-service training programs for healthcare workers in countries such as Kenya, Uganda, Tanzania, Zambia, Malawi, Senegal, and Lesotho. Diana believes that appropriate technology and innovations used the right way contribute significantly towards the development of responsive human resource for health in Africa. Our second panelist is Dr. Peter Bratensbach. I hope I pronounced that right. He's the head of product and strategy at Mezzanine Ware Pty Limited. Dr. Peter is head of product and strategy at Mezzanine Ware Pty, a subsidiary of Vodacom Group. Mezzanine creates digital solutions that enable productive societies and work within all mobile network operators in Africa to leverage a shared service platform across different industries, verticals, and market segments. His experience as a medical doctor, tampered with many, mostly fun, and always fulfilled years in biomedical technology, consulting, and innovation space, informs solution design and deployment, especially with respect to the re-engineering of primary healthcare in Africa. He is based in Cape Town and has a passion for botany and mountains. Our third panelist is Victoria Austin. She is the CEO of the Global Disability Innovation Hub CIC, a non-profit social company based at a GDI Hub's UCL Research Center, a global collaborating center with WHO on assistive technology. GDI Hub has emerged from the legacy from the Paralympic Games in London, which Victoria led for 3 mayors of London, and exists to power disability innovation for a fair world. GDI is currently operational in 38 countries across more than 30 projects and has so far reached 4 million people through a profile of £50 million program. Victoria is also program director for the FCDO funded 80-20-30 program, which is investing £20 million to find out what works in getting assistive technology to the people that need it around the world, and a technical assistance program for the Asian Development Bank. She has a master's degree in social development in practice and is in her final year of PhD focused on inclusive citizenship for disabled slum dwellers in Freetown, Sierra Leone, at the Development Planning Unit in Butler School. Fourth panelist is Rob Winters, MD Rebel East Africa. Rob is the managing director of Rebel East Africa in Nairobi. Rebel East Africa is part of Rebel Group, a financial consulting firm with 300 staff worldwide. Rebel has worked in over 100 countries on more than 150 infrastructure projects with a total value exceeding USD 35 billion. After spending 5 years in headquarters in Netherlands, Rob has moved to Kenya to set up the East Africa office. A senior economist and PPP, that is public-private partnership expert, he has worked in a range of African countries across all infrastructure sectors. Currently, Rob works on a range of projects, including establishing a PPP for healthcare in Isiolo County in Kenya and establishment of the African Urban Sanitation Investment Fund for the African Development Bank. Other recent experiences include, example, a blended finance study in Rwanda and setting up a PPP for healthcare in Makueni. Our fifth panelist, Dr. Precious Lunga, CEO and co-founder of Boabab Sacco. Dr. Precious is CEO and co-founder and an award-winning technology company using AI-powered platform to deliver personalized management of diabetes, hypertension across Africa. She has previously worked at Econet Wireless, where she established Econet Health and launched several services, including Health Tips platform, which acquired more than 750,000 paying users within its first year. Prior to joining Econet, she was strategic advisor to the Children's Investment Foundation. Precious has worked as an epidemiologist across Africa and UNAID Geneva. She sits on the board of London School of Hygiene and Tropical Medicine, Grassroots Soccer UK. Precious has a PhD in neuroscience from Cambridge and is Yale World Fellow. Lastly, we have Chris Harrison, the managing partner, of the Ivy Fund and CEO of Stepwise. Chris' work is dedicated to providing job and career opportunities for disadvantaged communities, predominantly women, the chronically unemployed, and persons with physical disabilities. The Ivy Fund invests in businesses that leverage on digital technology to enable people with physical disabilities and people from the marginalized communities earn a living wage, build a better career, and participate fully in civil society, and to help unlock the untapped potential of the differently able to become self-sufficient and positive contributors in society. I believe, Robert, I have introduced all our panelists, and we can move on to the next segment in the program. So I would love to welcome Florence from Malawi, who is going to kick us off with a demo of Leap platform. And she's going to tell us more about what that is within the healthcare sector in Africa. Welcome.
Thank you, Bernard. I'll take you through Leap demo. Leap actually is an innovation that AMREF came up with in terms of improving access to healthcare for people in the communities. So basically what we do in Leap is that we build the capacity of healthcare workers, especially community healthcare workers, with by using a mobile phone to teach them in different aspects of health. So this will come with a short presentation on how Leap works so that we appreciate how the innovation is working. I need to share my screen. So when we were coming up with LEAP, we looked at some of the challenges that are existing in the context of healthcare provision in Africa. Basically, a study that was conducted in 2016 indicated that the community health providers need support in terms of their healthcare delivery on family planning, maternal healthcare issues, and a number of cases. Actually, we saw that there's always increased demand in capacity building for healthcare workers and staff, and also the need for ongoing training, because we know the context of healthcare always changes with the coming in of new diseases and even treatment. But on the ground, we always appreciate the work that our community healthcares do, because these are the first people actually to meet people in the communities before they go to the healthcare facilities to meet professionals. So basically, the community healthcare workers play a very crucial role in terms of healthcare service delivery in Africa. So LEAP came in as a solution. So LEAP is basically a platform that incorporates healthcare providers at different levels in terms of the care that they provide by teaching them in different aspects of health. Yeah, so learners actually learn depending on their demand. So basically, the way the platform was developed is that it allows learners to learn different topics based on the needs on the ground. And also the platform itself is so easy to access because it uses a mobile phone. So even community health workers with a simple basic mobile phone can access the learning, because actually on the ground, they do not even need internet or airtime to access our learning tools. What they need is just to have a mobile phone, which we know in our context these days, almost everyone has access to a basic mobile phone. Yeah, so LEAP was made in a way that even people in the hard to reach areas can access it. The other thing is that also LEAP is easy to access because it even incorporates the job aids that our community health workers need on the ground to deliver services to the people. Yeah. And the other thing is that it also takes in partners in terms of their service delivery. So when you come to supervisory tools that the Ministry of Health wants to incorporate for the community health care workers when they are doing their work, they are incorporated in LEAP as well. And also the other thing is that different partners come in with different information that we would want to incorporate as things are changing in the health context. So we keep updating the platform now and then, and healthcare workers are reached with recent information when they are running. Also with this technology, the other thing that we have noted is that it saves time. Basically with face-to-face training, what was happening was that most of the community healthcare providers were missed out because it was not easy to reach them, especially in the hard to reach areas. Information was taking wrong. As such, the services that they were providing to people on the ground was compromised, and even the messages. But then with the coming of LEAP, once information is loaded in the platform, just at a click of a button, they are able to access the information in the platform. And also the good thing is that the platform itself creates digital recording, because whatever the learners are doing in the platform, we can later access it, and we are able to track the performance of the learners. As such, the community healthcare providers are given support and are also helped based on their needs on the ground and the gaps that have been recognized. Yeah. So the product itself in this innovation is just a basic mobile phone, because that is what the community healthcare workers use in the provision, in the learning process. So basically the learning happens virtually. Because of this, you can see by yourself to say that it is very convenient, because the learner access the information anywhere and at any time when they need it. They can also use it as reference when they are doing their work in the communities. Also, the platform provides a chance for them to do assessments in different ways. So they are able to do quizzes with their mobile phone. They are also able to collaborate with their fellow community health workers on the ground. So they have peer chats, and also they are able to communicate with people in their communities just by using the mobile phone. With this mobile phone, even a basic mobile phone, the learners are also able to interact with their supervisors. So the supervisors are able to give in add-on information, and as well as to supervise them as they are doing their work on the ground. So LEAP as a platform, as a platform also provides linkage with other stakeholders in the way it functions. As you can see from this slide, as much as AMREF is the provider of the service, we also have Trio, which we incorporate with in working in providing the service. So Trio supports us basically in the production of intermittent voice recordings. So these are messages that we give out to the learners. You know, the community health care workers, basically, their levels of education sometimes are not that high. So we tried, the platform was made in a way that everyone that is working at community level can access it, even those that have struggles in terms of reading. So we incorporate voice messages so that learning becomes easy for people on the ground. Yeah. And then Mezzanine is the main host of the platform. And then we also work with service providers in different countries. Like for Malawi, we work with Airtel, TNM. So these are the providers basically that sends out the messages to our learners on the platform. As the learners are learning, this is what they go through. Actually, the learning process itself is very simple because it is very easy and convenient. Learners are able to finish a topic even within 2 to 3 days with all the assessments. And the good thing is that they are rated in the platform, and they are also encouraged, they are given reminders in the learning process. Through the text messages that they receive, they are able to follow the learning process, as you can see. So they are received in the platform, they are given their introductions through the text messages that they receive. And also, they receive role plays. So these role plays basically help them to make their learning process easy. As I said, that some of them to comprehend issues because they are not professionals, it's not easy. So we tried to make the platform easy, and we contextualized it based on the standards of the community health care workers in Africa. So basically, that is what was established on the ground. So we included low praise deliberately to make the learning exciting and easy for community health care workers. The other thing.
Thank you. If you can just wind up in a minute or less, please.
Okay, fine. So lastly is the group chat, where the learners, as I said, are able to interact and also interact with their supervisors. So through all these learning processes, as you can see, AMNEF has this business model where we have a pool where we are putting in together different donors, even the Ministry of Health, different organizations and partners that are bringing in different information regarding health that would help us improve the health systems. Yeah, and through that, AMREF plays the role by giving the information to our health care workers, and then the learners basically benefits on the ground with this information, and then disseminate it to the entire community as needed. Thank you.
Thank you so much for sharing with us about LEAP. And this is really a great introduction or a good way of getting us into the deep end of what we're talking about when it comes to inclusive innovation. It's a platform that is built for community health workers, and more so community health workers that are serving the populations that are in very remote areas. And you've highlighted already a few points as to why that was important, the issues of the cost of training, for example, and how you've leveraged technology to solve that. So I'm going to call on Diana, because I know, Diana, you've been working on LEAP and many other technologies as part of the work you're doing at AMREF. Why is this important to you? Why do you really want to invest so much? And how has the journey been? Is it as easy as Florence has shared with us? Was it, you connect with mezzanine and lo and behold, everything works and we're scaling? What's that journey like?
Thank you, Robert, and thank you, everybody. I'm really excited to be part of this discussion. And when I look at, what the theme for this conference is about, this is the decade for action, and we're driving momentum towards achievement of UHC in Africa. I think from listening to yesterday's discussions and today's discussions, 40 years, more than 4 decades, basically, after the Alma Ata Declaration, I think it's clear that we all know what we should be doing in terms of providing primary health care so we can achieve universal health coverage. And so at the core, if you look at UHC, at the core of it, one of the pillars is about providing equitable access to quality health services. So when we talk about this panel and what we're discussing around innovation and specifically around inclusive innovation, I think one of the ways that AMREF looks at that is from an equity lens. So how do we make sure that, how do we define, inclusivity through equity? So we look at, some of the components of equity, some of which Florence has touched on, everything from geographical location. So how we make sure that whatever innovation is there is accessible to you regardless of your geography. If you look at sub-Saharan Africa, we have the rural urban divide, and we also have very remote locations. So how do we make sure that whatever innovation, whether it's technology or non-technology, is accessible to these communities, because we want to make sure that we can provide the right quality of services. If I look at the training of health workers, which is one of the things that we do, Florence touched on looking at what kind of technological infrastructure is available to, for instance, our community health workers. And so the development of a solution that uses basic mobile phones is not an easy thing to do, because even how you deliver the content, there is actual cost to it. But then if you don't do that, that means you're excluding community health workers just because of what technology infrastructure that they have with them. So, the question about collaboration and partnerships comes into play, and needing to work together with different stakeholders to be able to achieve that. If you look at other aspects of, equity is around, things to do with culture, for instance, or language. So as we're developing our digital learning solutions, we want to make sure that, whether you speak Swahili or Amharic or Chichewa, whatever it is, that the content that we develop, of course, needs to be aligned to, the Ministry of Health in a particular country, whatever regulatory framework exists. But really what you're looking at is, at the end of it, can this health worker that you're targeting be able to understand and acquire the skills that they require so that they can then provide the required services. So there was a survey that was done, I think it was 2019, a global survey that was done. I think many of you are familiar with it, the What Women Want campaign. And the question was, what do women want as far as maternal health is concerned? And I think the expectation was that, you'd have the usual answers of, financial resources, things to do with supply chain and so forth. So one of the key things that came out that was, I think, a bit surprising for many was the fact that the women who are actually receiving these services, what they value, what they see as quality is respectful care. So that is what they see as quality. So regardless of what qualifications you have as the midwife, as the doctor, as the community health workers, for them, if you're not respectful to them in terms of, their culture and their traditions, and you're able to provide services within that, then they do not see that as quality. So the question is then, as you're developing your innovations, how do you make sure that You look at the different users across the value chain of providing health services. So yes, you want to align with the Ministry of Health policies. You want to make sure that whatever the regulator is, that is covered. You want to look at the training institution and the trainers, what do they need? And then the trainees themselves, what do they need? But ultimately, what you want to make sure is that you're providing, access to quality health services. And the question of quality then becomes really important, and the need to include these communities in defining what those innovations are is really critical. And you can look at different other angles around equity to do with gender, with disability, religion, education levels, socioeconomic status. So as we develop, I think innovations at AMREF really do look at the things that we need to consider from the context, even within countries, whether you're training nurses, there will be differences between countries. So what works, for instance, in the Western world is very different to what will work in sub-Saharan Africa. And even within the region, there have to be contextualizations or localizations to make sure that whatever you're training is really responsive to the specific community that you're working with. So we look at using a human-centered design. It is not inexpensive, but it is our duty to do that, because then if you're going to talk about providing quality health care services, then we must make sure that we're inclusive and we're taking into consideration the individuals, the different groups that we're serving, like I said, from an equity perspective. So those are some of the things that we're doing at AMREF in terms of making sure that we consider our users and the communities we work with to make sure that our innovations are inclusive.
Thank you so much. And actually you've given us so many interesting and good points that the minute I'm like, I've just gotten that one, then you'd go on to 2-3 more. So thanks so much for sharing with a lot of depth. And Peter, maybe if I was to come to you, because I think I also saw the organization on the slides that Florence just shared. And you're joining us from South Africa. How much of that journey that Diana's just shared resonates? Are things the same? When we look at South Africa, we see there's South Africa, then there's the rest of sub-Saharan Africa. Does it cross over as easily, or is there a difference in the way in the approach you take towards making innovation inclusive?
Thanks, Robert. It's a bit of an unfair question because we've worked for so long with AMREF that they almost feel like a twin organization. I mean, we see things, I think, in the same light, and in so many respects. I mean, I think when we were discussing this yesterday, our view with respect to inclusive innovation, I think is very similar to what Diana just mentioned now as well. That's our market. That's who we are designing for. We want to make a difference to people's lives. I mean, our whole raison d'etre is about making societies more productive. It's a shared value ethos. We are a commercial company and so forth. And I think by virtue of what we do, we are bringing people and beneficiaries and citizens that are ordinarily or often excluded from participating or engaging with enterprises and with a set of different services from very diverse stakeholders in different value chains. So we focus not just on healthcare, but in agriculture and so forth. So that for us is our mainstay. We go through a very sort of deep process of trying to understand the why. Why does this problem actually exist? And I mean, Jacques, our founder, and myself and others over the last 10 years have spent a lot of time in many different markets in Africa, walking that first mile or the last mile to actually understand what does it mean when you say there's a stock out, and why is there a stock out? What does it mean when you can't do the whole ethos around LEAP, where you can't easily engage with remote cadres in order to promote and drive continuing professional development? So how do you take this willing audience and use technology in a wise, intelligent, rational way that certainly from our case, We don't charge our beneficiaries. I mean, they don't pay to access the services. We monetize it on an enterprise level. So how does someone do that with, with intelligence and so forth? And we spent a lot of time trying to understand, the why, which is quite different from, I think, the way, for instance, many mobile network operators would provide services. So it requires quite a jump, but we've been doing it now for 12 years. We're now in 11 markets. In total, probably about 65 million beneficiaries have used our products. And we, as I said, we do a lot of work in the agriculture space, but also in the healthcare space. And just to give you an idea of one of the things that's really difficult about healthcare in particular is that it's a complex adaptive space. And we kind of discussed this very briefly yesterday. And it's complex because there's not one actor that can play the entire piano, as it were, all the instruments in the orchestra. There are many different players that are required to be able to do this. But if you lack the timpani, or you lack the trumpet, or you lack the piano player and so forth, that orchestra just does not sound the same and so forth. But what tends to happen is that people land up in organizations, land up having to adapt around that and so forth. So that's the one thing. And I think for us, when you try and introduce new things into this complex adaptive environment, in itself, that's disruptive. And often the stakeholders, I think, experience as a risk and so forth, for a start. And because there's so much disruption to all these different interlinked systems and agents and so forth. I think another thing that we've learned over the years is that it requires very patient stakeholders, particularly from an investment or a capital allocation point of view, for a start. These are not things that are easy to achieve at scale in a short period of time. Another important point is that the total cost of ownership is often perceived to be high, and I think that's partly the fault of the organizations that do this, for a start, because they don't often clearly articulate. It often has a very deep technical bent to it. So it's not a language that's easy to understand and so forth. Often with some of these things, the literature around them is gray literature. So from an outcome and an impact point of view, because they've only been around for a very short time, it's difficult to conclusively prove, what that benefit will be to a healthcare system and so forth. And I think in addition, people often make the mistake of considering the value proposition from a functional perspective. What can this thing do? Rather than understanding what the non-functional components are, which are critical. I mean, the one we get asked all the time, and justifiably so, is can you integrate with, for example, other logistics management systems? And you have to. I mean, that's just the way it works in the space. So people, I think, need to sort of change the lens of how they look at these things and how they value them. Yeah. And then for us, based on 12 years of experience, getting it wrong frequently, we've come to really deeply appreciate anyone who tells you that they work for an implementation partner. They automatically get respect from us, because these things will not easily be successful and scale unless you have a credible partner that can support that journey in the field, very importantly, not just sitting in the, in an office in the capital and so forth, but can hold the hands of those beneficiaries and of those users. And the thing is, implementation is low tech, but it's high touch. There's a lot of friction involved. So it attracts a cost, which often, is in excess of what the technology cost is. But without that, the technology that we do and some of our colleagues and competitors do doesn't ordinarily or easily work. And then I think lastly, just on this, is that when people look at these kinds of solutions, they almost look at it from an accounting point of view of a dollar for dollar kind of comparison. And I think one needs to look beyond that at the sort of broader socioeconomic benefits of what we do. A good example would be around, if you provide citizens with a digital identity, in other words, an economic identity, they can now start engaging with enterprises. You look at M-Pesa and an example around financial inclusion. These were things that have just mushroomed for all the right reasons. So, yeah, thank you.
I hear you, and I think this is really great answers even to the question. I think I've seen a question on the chats from Frederick Majiwa as to why is it so difficult for technologies to be adopted, and I think Peter, you've really spoken to the heart of that. It's a problem solving, it's a systems thinking. It's about integrating something into a very conservative, maybe some very difficult problems to address. And I'll hand over to Bernard for the next questions. And yes, Bernard.
Yeah, thank you, Robert. And just to shift gears a little bit here and kind of take a deep dive a little bit into one of the verticals. So Vicky, you work at the intersection of disability research and innovation. What does inclusive innovation mean for you and for GDI Hub? And why assistive technology?
Thanks, Bernard. It's been really interesting to listen to the panelists so far. And thanks for inviting me today. I'm joining you from Oxford in the UK. I think inclusive innovation is innovation for all, and it's also innovation by all. So I think oftentimes we assume inclusive innovation means innovating for a particular subgroup of the community who might not have access to a particular thing. And that can be true. But I also think it's about accessing the latent talent that we have amongst the community members that are not able to participate as entrepreneurs. And that's something that I think Bernard has already unearthed through the work he's done with Innovate Now with our partners AMREF in setting up the first ecosystem on assistive technology in the world, I think, as well as in Africa. And so in the third round now, we've seen a bunch of innovators coming through with really great ideas and really great purpose that we've been able to support on their journey. And I'm sure at the pitch day next week, we'll see much more of that. But actually, inclusive innovation is also about specific types of innovation for us. And for GDI Hub, that means a really strong focus on assistive technology. And that's technology that helps people to live independently and freely and participate in their families, their communities, in education. And oftentimes we talk about that for people with disabilities, but it can also mean older people. And actually, we know from the World Health Organization that by 2050, 2 billion people will need access to assistive technology. So this isn't just latent entrepreneurialism, it's also a latent market. We know, for example, that at the moment, 9 out of 10 people who need assistive technology do not have access to that assistive technology, which means 900 million people need a piece of technology that they currently don't have. Now, if we think a little bit more about what that means, a piece of research by AT Scale recently found a 9-to-1 potential return on investment for providing assistive technology. That means that if a government is able to prioritize the purchase of assistive technologies, eyeglasses, wheelchairs, hearing aids, they might see a return of up to 9 times that, because the person is able to operate within society in a kind of fair and open way. So latent markets, we've estimated it's about $100,000 per family on average would be netted as a benefit if that person was able to participate in society with that piece of technology. So lots of latent space to go into. How do we go into it, and why is it difficult? It's difficult because I think as previous speaker said, not one person or one organization is able to do this alone. The problem is systemic. We did a big piece of research, lots of work. We just published product narratives on the different market sectors with Clinton Health Access team, thank you very much, including one that focused on Kenya and wheelchairs. We've published pieces of work with the World Health Organization on what to procure, how to procure, what are the standards. That just came out last week for 26 products. But actually what's missing is a systems approach. And if we don't take a systems approach, then fixing any different piece in the system isn't going to result in the outcomes we want. And we have to do that in partnership, which is why things like today are so important. Oftentimes with our work, and we launched an AT, Assistive Technology Impact Fund last year. It's a test. It's 4 million at the moment of FCDO funding. We launched a call 2 weeks, and we received 90 applications, of which half were good enough to peer review, of businesses that are already in the marketplace for assistive technology. And we are able to support only 6. So if anyone would like to join our circle of investors, now's the time to give me a shout. But the point is, what we need to provide those businesses is not just capital investment. They also need business model support, because getting the product right, and our universities and our colleagues on this partnership will tell you that it's easy to sometimes get the product right, but unless the distribution channels work, unless the awareness works, unless stigma is reduced in the community, we can't address these things. And so our first 2 investments, one in Herex, which is a South African company who are about to bring their product to Kenya using new mechanisms of smartphone-enabled hearing assessment and testing to get the products to more people. And we've had to wrap around an innovative payment model, because people in communities can't always afford that cost, but maybe their urban relatives can. So that's one example. And the second and final example is Wazi Vision, which we were really proud to invest in with a group of female entrepreneurs out of Uganda, who are providing $19 eyeglasses. And so these types of companies and products that we're working with now are just the tip of the iceberg. But I truly believe that if we're able to make these kinds of investments in collaboration with each other, we will end up with the fairer world that we all want to see. And I think assistive technology is a really good case study for how innovation can work really inclusively in other spaces too.
Absolutely. Thank you so much, Vicky. And I think just picking up on one thing that has stuck for me is, innovation for all and by all. And I think at this point, I want to rope in Rob. Rob, you sit at the intersection of funders, investors, and those receiving investment to implement. So what does inclusive innovation sound like to someone sitting at that position? Do you think there is clear understanding on one side, on the investment side, and for those that are driving this change on the ground? And how can you link that with the partnerships conversation? Because Vicky tells us that it's going to take partnerships, meaning that the place for public-private partnerships needs to expand to advance this mission of inclusive innovation.
Thanks. Yeah, thanks a lot. So I'm joining you guys from Nairobi. It's great to be on the panel. Thanks. And I've heard a lot from the previous panelists that I was actually going to include in my answer. So it's about bringing the pieces together, probably. So as Diana already said, inclusive healthcare is pretty expensive. So what should we do to make it more affordable? I think technological innovation plays a role, but also financial innovation. So if you look at it from a financial perspective, we should use probably, I can think of 4 angles that we try to use also in practice. One mentioned by Peter is also look at this from a CBA perspective. So look at it from a cost-benefit analysis perspective. What are the costs you're actually avoiding by intervening? And what is it worth for you to avoid those costs? If you look at climate finance, and I think this is one of the few areas where climate finance is ahead of health financing, where you see that a lot of funders are prepared to actually pay to avoid costs in the future. Second thing is governance. The government should be able to come up with attractive propositions for the private sector, and they should be asking for results, and they shouldn't be asking for products. They should be asking for improvement of health indicators, and then again, what is it worth? What are you willing to pay for it? And this triggers innovation. And I mean, innovation will not make healthcare inclusive for all, but it will make it more inclusive. And over time, it will reach the bottom of the pyramid as well. Third thing is blended finance. So what we try to do in partnerships, in public-private partnerships, is to make the services more affordable by blending finance, so concessional finance, guarantees, viability gap funding, and yeah, probably the one where it all comes together, and that's also Peter's piano, is in bringing actors together, because I also see that the healthcare system currently is complicated. It is more difficult to operate in that space than most other sectors. So one way to solve it is in partnerships. What you see more and more, what we're trying to do in healthcare is that NGOs, private sector, and government try to work together in a public-private partnership. They try to pick up the healthcare system, in fact, and they want to improve it, and they take a period of 10, 15 years for this. And that's different from what you see now a lot in practice. The scattered approach, actors setting up projects for a period of 3 to 5 years sometimes. So yeah, if you can bundle this in partnerships, then you can make also the financing of it more affordable, and it's going to be easy to finance your products. So and look, yeah, finally, look at this as an economic sector as well. So there, and look at the opportunity cost of the actors involved. And I think that's sometimes something we fail to do in Africa. And we've seen also with COVID that being too dependent is in the healthcare system can be disastrous. So find your niche, start producing, and start providing to other countries. See healthcare as an export product. So see this as an economic sector, and that's where we can gain a lot. Thanks.
Thank you, Rob. And maybe we can switch gears, not so much from finance, but looking at it from the VC perspective. And Chris, I think you as the managing partner for a fund investing in inclusive innovations, can you share with us, how do you see this landscape? Is this something, when we're looking at health in Africa cross-board, the first thing we see is the market failure, very underserved market. And then now within inclusive innovation, we are taking that even further to a much more niche, neglected market. Can this be a place where you can have venture-backed, startups, innovations that can sustainably deliver universal healthcare?
Well, I certainly hope so, because I've got some money to put at risk, and if it can't, then I'm going to lose a lot of money. I think what's been really interesting hearing everyone talk this morning is just the recognition that we all have that this is a systems issue, right? And so there are changes and innovations happening at multiple levels. I think both Florence and Peter talked about that last mile issue of how do you actually you've got a great idea, but you've actually got to get it implemented on the ground, and how does that work? And that's super complicated. Peter and Victoria talked about sort of these positive externalities where you can look at one way and saying, oh my gosh, you've got this massive unbanked population, and then something like M-Pesa comes up, and oh my gosh, it's designed to solve one problem, but it really enables solutions across a whole range of issues. And so I think one of the things that has me interested in this space and positive on this space is that we've got an ecosystem, I think, that's getting built that is open to these looking more broadly at the opportunity, right? So it's not simply, well, I can build this product for X and sell it for Y, and there's my margin, so I go out and raise some money from a VC. It's more about collaborating, right? So enabling or creating the systems and structures where you get sort of this more organic problem solving, more localized, as opposed to importing technologies from the West, and then trying to apply it in an African context, saying, hey, what's actually going on here in Kenya? What are our problems? What are our impediments? And how do we create solutions that address all of those? And I think from my perspective as an investor, taking a step back from, can I create one product that sells 1 billion units and makes me rich, to can I invest in an ecosystem, right? So I've got maybe a series of smaller investments across multiple players in a space where I can take a small piece of a bunch of little transactions and make a return on investment that way. So I do think there are investment opportunities here. And the nice thing is, and I think Victoria brought this up, and I frankly had not thought of this until she said it, you've got an aging population that is going to, in many respects, mimic the population of persons with disabilities. And so again, just sort of looking more holistically at, I'm not trying to solve this very narrow problem. It's actually a problem that's shared, by much larger populations. So being able to solve them in an ecosystem-wide or a more collaborative way is really exciting.
And I think you just answered my follow-up question, which is what I hear from every investor when you're raising funding is, what's the exit? and you're right. This is one niche market, but it's a bigger market altogether. And there's lots of scope for even reverse innovation. And maybe on that note, I'll go to not our last finalist or our least important panelist, but Dr. Lunga, if you can share with us a little bit about the scope for artificial intelligence. And I think Chris has just highlighted very briefly about Safaricom and how it became a massive disruptor. You're coming in as an innovator, as an AI specialist, looking at it from your angle that makes you feel that even in low resource settings, there's actually scope and room for artificial intelligence to have some transformative impact.
Thank you for that. I first of all want to say that the role of data is important across all settings. And particularly when you're resource constrained, you need the data to make decisions. And data is the basis of actually forming any sort of artificial intelligence. And that's where we started at Baobab Circle, because we realized that people living with chronic conditions like diabetes and hypertension were ending up with poor health outcomes because of a lack of data to support decision making. Decision making at the level of the health facility, and decision making at the level of policy making, but also decision making at the level of the individual. Because if you don't know what certain behaviors can trigger, you will not do the pro-health behaviors you need to do. So that's where I want to start, and to say that's where what Chris and others mentioned about not necessarily importing technologies or products from I guess resource rich settings and just copying it. Why Baobab Circle was set up and why our Afia platform was set up was because we realized that people living with chronic health conditions, some of them would only be seen by a facility maybe 4 times a year, and yet there are all these data points in between, and no one was tracking them, and so by creating a platform that enables users to gather that information and create insights, we're then able to actually start to see a real improvement in outcomes. What is key, and I really like the fact that everyone keeps referring to it, is that because the health system is complex, but the impact of what we do is therefore enormous. Globally, because of COVID, we've all realized how health is I mean, it impacts economies. It's as people along, but now it's shown, COVID has shown us in a big way. And so where I see this is a capacity for partnerships, and to be able to then share data and information across the partnerships in order to advance the goal of what we're trying to achieve. I'll give you an example. With our so 1 in 4 people, 1 in 4 adults across Africa has hypertension, for example. But we know there's certain things you can do to reduce your high blood pressure, which then of course reduces your risk of damaging your organs and your risk of having a poor COVID outcome if you get COVID. So we're actually working with community groups on the ground to develop the product service. Really, I should call it a service, because health is always about service, not the product. And also working with the ministries of health to see how do we actually plug in with how the system works, so that we can adapt this and make it as seamless as possible for the user. And I think that's where combining the partnerships in collecting the data that's needed to create the artificial intelligence algorithms, because they're only as good as the data you get. And I encourage that anyone working in the space really focus on collecting that data well, because the more data we get, the more refined we'll be, and the more we'll start to even be able to predict and identify not only what the pandemics that are happening now, but future ones, so that we can prevent them. Thank you.
Thank you so much. And I think you've really helped us to understand it's not just something that is timely, because as you're saying, here we are talking of hypertension, then there's a convergence with the COVID pandemic, and then building it out to understand how do you engage the Ministry of Health and to be able to actually reach the patients that really need the care. So there's lots of systems, and I think that has come up so many times. And I for one, I'm really walking away from this with renewed vision of just how much more we need to work together across the multiple sectors, whether it is those who are actually doing the heavy lifting of building the technology and coming up with the solution, not just in terms of the technology, but also the business model to deliver it and to scale it, to those who are looking at the implementation, to those who are looking at the financial solutions that also need to be developed alongside the technology, because technology is definitely becoming a game changer. Things that were not possible before are simply becoming all of a sudden things that are credible and worth looking at. So there's lots of need for further discussions, and unfortunately, I'm realizing that we are almost out of time, literally out of time, and I'd have hoped to have a few questions from the audience. We've seen one question about the issue of adoption from, I think, and that has been answered from Frederick. And there's maybe one more, I think it's really more of a comment from Dr. Bernadette Ategang regarding the issue of legal frameworks and ethical guidelines for telehealth. And that is really another sticky point. We're seeing a lot of countries coming up with regulation that demands for data to stay in the country, to be domiciled there, hosted there, and that becomes a challenge when we're trying to scale. It only adds to our costs. And is this something that even from the the African Free Trade Agreement that was just kickstarted the other day, I wonder whether our voice can be heard within that kind of discussion. So, but for now, I think we will be able to stop there, and I want to quickly thank you for making the time to be able to join us and for your attention in this session. After we conclude, I want to kindly request you to please return to the auditorium on the conference platform to view the next sessions and to be able to be a part of the ongoing discussion in the conference. Thank you very much and have a good evening.
Thank you.
And thank you to our wonderful panelists. Thank you everybody for being able to join us.
Thank you.
Thanks.